A very good morning to all. The content of this month is on the topic oral complications of diabetes mellitus. So diabetes mellitus, what is diabetes mellitus? It's the most common endocrine disorder which is affecting the metabolism of carbohydrate, protein, and fat. The major cause it is due to the absolute or relative deficiency of insulin secretion or with varying degree of insulin resistance. So it is a group of metabolic disorder characterized by hyperglycemia, that is increase in the blood sugar level resulting from the defects of insulin secretion, insulin action, or the both. Long-standing diabetes mellitus has a complication of microangiopathy, that is nephropathy, retinopathy, neuropathy, and aggravations of the microangiopathy. So coming to the classification of diabetes mellitus, majorly it is of four types. Type 1 diabetes mellitus, which is insulin dependent. Type 2 diabetes mellitus, which is insulin non-dependent, gestational diabetes, and others. Others are due to genetic defects of the beta cells or the genetic defects in the insulin action, and it can be due to other causes like infection, genetic syndrome, endocrinopathies, drug-induced or chemical-induced diabetes mellitus, are uncommon forms of immune-mediated diabetes. Coming to the topic of today, oral complications of diabetes mellitus. Diabetes mellitus, when in an uncontrolled level, majorly when the postprandial sugar is more than 126 grams per deciliter, it can majorly affect the periodontium, which is the common oral finding in a diabetic mellitus patients. So what happens is the patients tend to develop periodontal diseases, and it is due to the increased glucose level, which indirectly alters the response of the periodontal lesions to the local irritants, hastening the bone loss and retarding the post-surgical healing of the periodontal lesions. The increase in glucose level in the gingival fluid favors through the growth of the microflora. The patient exhibits fulminating periodontitis with periodontal abscess formation, which is the more common finding in the diabetes mellitus patient. This will give rise to the mobility of the teeth when there is severe and rapid alveolar bone resorption. So this is the pathophysiology, how diabetes mellitus affects the periodontium. There is advanced formation of the advanced glycosylated end product, that is glucose plus hemoglobin, which results in collagen accumulation in the periodontal capillary basement membranes, causing the membrane thickening and narrowing of the vessel lumen. This narrowing of the vessel lumen decreases the oxygenation to the tissues, which alters the tissue response to the periodontal pathogens, thus resulting in an increased tissue destruction and diminished repair. The second major oral complication is oral candidiasis, which is an opportunity infection caused by Candida albicans. When there is a poor glycemic control, it leads to dry mouth, which can increase the accumulation of the Candida species, leading to a curdy white patch, which is scrapable on the oral cavity, that is oral candidiasis. The third more complication is the poor wound healing. When the patient is subjected to extraction, the wound healing would be delayed, or it could cause localized osteitis or dry socket. The wound healing capacity is delayed due to decrease in the polymorphonuclear chemostasis and impaired immunological balance due to increased production of matrix metalloproteins, that is MMPs, such as collagenase. The decreased level of the anabolic bone hormone called osteocalcin, which is the gamma carboxyglutamate protein, can also cause to delayed wound healing. And the patients with diabetes mellitus are also more prone to the formation of root caries. This is or the increased caries activity, majorly the root caries. This is due to the complications, the coexisting complications like xerostomia, which is a dry mouth, increased glucose level in the saliva and gingival clavicular fluid, which stimulates the bacteria to accumulate in the cervical region, and the thick saliva due to the thick floppy saliva due to excess glucose, and decreased flushing action. As there is a low level of salivary secretion, the flushing action of the saliva is compromised, and it is also the salivary flow is also decreased due to neuropathy effect. Next is a adenosis, diabetic adenosis. This is a non-tender diffuse bilateral enlargement of the parotid gland. The disturbances in the anatomic sympathetic innervations causes a dysregulation of the protein synthesis, result in cytoplasmic swelling due to the enlargement of intracytoplasmic zygoma granules within the ductal acini, which in turn causes the salivary enlargement. Xerostomia, which is called as trymo, the side effect due to the drugs or the medication taken by the patient for the treatment of diabetes mellitus like metformin. And the other cause is a neuropathic cause where there is a change in the sympathetic and parasympathetic core. And it also could be age related. Both diabetes, xerostomia and diabetes are more prone to occur in the older age. So summing up the oral pathology related to diabetic mellitus and their treatment, periodontal pathology, it is due to the accumulation of advanced glycosylation in products in the periodontal tissue, which decreases the periodontal regenerative capacity and defective immune regulation. This can be prevented or treated with assessment of risk of disease and periodic reviews, dietary advice, and periodontal therapy. Coming to trymo, this is due to reduced salivary flow as a result of older age or neuropathy, or due to medications taken during for the treatment of diabetes. And the proper treatment is proper diabetic control, and you can improve the dental hygiene. And side logs can also be given. Root caries, it is due to result of gingival resorption and decreased salivary flow, which provides an environment for local factor accumulations, and there is no flushing activity of the saliva. So this can be prevented by using a fluoridated paste, restorative treatments, and controlling of the glycemic level. Oral candidiasis, this is coexisting opportunistic function due to dry mouth, and because of the salivary dysfunctions like and hyperglycemia and immune system. The treatment would be antifungal, nystatin, or mignocortisol treatment. Good glycemic control is also essential. Coming to the pulpal necrosis and periodontal abscess, the ischemic tissue damage related to pulp or owing to the vascular damage from the diabetes. Treatment will be endodontic treatment and control of diabetes. Coming to the last part, delayed wound healing and increased incidence of infection following surgery. As we have said, there could be a vascular dysfunction and decreased immune to diabetes. Maintaining a proper control of the diabetic glucose level and preventive administration of the antibiotics can be a prevention for delayed wound healing. Thank you.